Welcome everyone. I see everyone trickling in. Delighted to be with all of you. Thank you so much for joining us. My name is John Arojave. I am with Cross Cultural Communications. If you don't mind, if you could, it's always too many people. I'm so delighted to be with all of you today. If you could put where you're joining us from. So we see Minnesota, we see Nebraska, New York City, Vancouver, Florida, Lexington. So please put into the chat. And yeah, no, absolutely excited to be with all of you today. So my name, as mentioned, John Aruchave. I'm with Cross Cultural Communications. I'm actually joined behind the scenes by my colleague, my wonderful colleague, Naisel Sabala, who makes everything run smoothly. She will be managing the chat. She'll also be sharing helpful links within the chat. We're also joined by our wonderful American Sign Language interpreters, Madison and Victoria. Please, Nicel is going to put the link into chat. Please hit interpretation if you need ASL interpreter support. Um, so just a couple of things, before we actually get started. Let's see. So list of our training. So we have our training of trainers actually coming up in July. If you've ever considered running your own sessions of the 40-hour course, the training of trainers is really a wonderful way to begin training interpreters. We frequently say it at CCC that language access is really core to health systems, to school systems, to nonprofits, to government agencies. It's core to healthy institutions, and interpreter training is core to language access. So if you want to become a trainer, if you really want to start moving the profession forward, we believe the training of trainers, the community interpreter international training of trainers is really the best way to begin training. It's 3 weeks. It starts in July. Otherwise, we have a glossary, an educational interpreting glossary that we will be publishing. This is always a little bit of a moving target, but within the next month or two. It is a Spanish to English educational interpreting glossary. Nicel will be putting the link into chat. And additionally, we've actually rolled out a self-paced course, The Educational Interpreter Online. We will have it completely finalized. It's going to be a 20-hour course when we're all done, 20 to 25-hour course when we're all done. It'll be done in about 2 months, but we have about 8 of the 11 modules completed. It's really an engaging, informative, very interactive, very appealing, sort of from a visual perspective and from a learning perspective course. It's very hands-on. It's very applicable. It's based on the Introduction to Educational Interpreting and Translation. So we think it's a wonderful resource. We're going to put that into chat as well. And just a few administrative things. So today's webinar is going to run for about 45 minutes. It's going to be followed by Q&A. If you have any pressing questions, please add them to the Q&A. You could also put comments into chat. The webinar does count for CEs, so within 2 to 3 days, you should receive a confirmation of attendance email from Zoom with a link you can download, with a link to the certificate. Please, download the certificate, add your name, save it for CE's purposes. Okay, and in terms of today's webinar, we're really excited. Today's webinar is about interpreting in mental health care. We are lucky enough to be joined by Dr. Zeyad, a physician with 15 plus years of experience in surgery and in internal medicine. He's also an NBCMI certified interpreter. He is an expert in clinical and pharmaceutical research, in medical translation, and in health communication. And so, Dr. Zayed, you're welcome to join us. He will be running through his presentation on mental health interpreting. Dr. Zayed comes to us with a ton of experience, both inside and outside of mental health interpreting. He's the expert, so I'll turn it over to him. Thanks so much for joining us, Dr.
Thank
Zeyad.
you so much, Mr. John, for having me. I appreciate that. Hi, good morning, everyone. How are you? This is Zeyad Juboori. I'm a certified CHI Arabic interpreter, and I'm thrilled to have you here for interpreting in the mental health webinar. We're gonna running together, guys, for share some very important obstacles that is facing the interpreters in general during those mental health sessions, and also try to share with you also the proven strategies to help you cope with these kinds of sessions. If you have any question, you can put it in the chat. And also, we have some question that when we go together through the webinar, some questions that you can answer, and we can go from there.
Wonderful. There we go. We see your screen.
Perfect.
And there's the presentation. Wonderful.
Okay, so this is the presentation. We have like 25 slides. We'll try my best to run through this 45 minutes. We have certain things we have to negotiate and talk about it. The very important things I want you guys please to focus on is two important things. What are the most common dilemmas and the obstacles that facing the mental health encounters regarding for the interpreters, and also what kind of strategies and guidelines we can interpreters. Again, it's around 25 slides. So we can just like a brief introduction. Interpreters in general need to know, have to like a broad across disciplinary knowledge, knowing a little about many topics. This is the interpreter today with mental health, tomorrow with surgery, after that with pediatric, So we should have like a lot of knowledge about certain or a lot of topics, even if it's little. I'm not a mental health specialist, but this content has been reviewed by a qualified psychologist. I gathered the information. We did this webinar, but to be like proven 100%. Also, this session is again, it's a general view. It won't cover all the topics in the mental health. I'm focusing mostly on of the of the obstacles that we might face, and also the challenges and how we can cope. And with these, we have certain strategies. It's not only about the mental health, medical jargons, or glossaries. The introduction, and then we have also to encourage you guys to continue self-study and professional development are strongly encouraged. You guys search for the resources to support you, and also to be very important to be familiar with the mental health concepts, which can reduce the challenging, when you go to those kind of sessions, and with more effective interpreting you're going to do for the patients. Now, we have some learning objectives. After completing this webinar, so you will be probably able to describe foundational mental health and the core concepts relevant to interpreting and those kind of mental health sessions. Also, you can recognize common linguistic and cultural challenges that you might encounter these kind of sessions. And also you will be able to demonstrate the application, especially the strategies and guidelines to effectively manage the challenges. So let's get started. So first, if you don't mind, if you can put your answers in the chat room. Now, question said, how many times have you interpreted in mental health or inpatient psychiatric settings, including during mental health crisis? So the interpreter, no, I have never interpreted in these settings. Yes, 1 to 2 times, 3 to 5. You can put your answers, please. Sounds like a lot of interpreters doing mostly between 6 and 10 times. Okay, that's good. So in general, like most of you guys have been encountered with these kind of mental sessions. So now, let's say, go to the definition of the mental health. Now, as you know, guys, the mental health refers to the effective functional of mental process related to thought, mood, and behavior, which enables the individuals to cope with normal life, stress, work productively, and contribute to their communities. So this is very important if you want to like engage in communities, communication with the peoples normally. So you have to have a normal mental health process, which is including the thought, the mood, and the behavior. Now, mental illness occurs when these mental functions are significantly impaired to the extent that they interfere with the individual's social, occupational, and developmental functioning. So individuals with mental health illness may experience difficulties such as maintaining employment, making decisions, sustaining interpersonal relationships, or experiencing an enjoyment and satisfaction in life. So, you know, that's they cannot do that because they have an issue. And that's the problem, because if somebody cannot socialize with others through the environment and the culture that he lives, so this is the big problem. Now, mental health conditions are highly prevalent in the US and also in the international too. Like an estimated 26.2% of American ages 18 and older, about 1 in 4 adults, suffer from a diagnosable mental disorder in a given year. And nearly half of individuals diagnosed with one mental disorder experience more than one mental health conditions during their lifetime. So this is like a statistics study from Johns Hopkins Medicine, the mental health disorder statistics. So that's why it's very important, you know, for like, you know, the providers studying these kind of mental health disorders, because they want all the people to be like mentally and mental health normally and engage in the community. Now, the mental health field services. Now, the mental health field is multidisciplinary domain that encompasses the assessment, diagnosis, and treatment and prevention of mental, emotional, and behavioral disorders. So it's kind of, you know, like multiple domains that's focusing on, again, like prevention of mental, emotional, and behavioral disorders. So it includes core services. For example, we have pharmacological management, which is like, you know, assessed and diagnosed by a psychiatric evaluation done by a psychiatrist, and medication management. These kinds, in, you know, like for prescribing medicine, you know, medications for people who need medicine in the mental health sessions, like people with depression, for example, schizophrenia. We have also psychotherapy. This might be individual and might be group therapy, which is, you know, aimed of changing thoughts, behaviors, emotions, and exchange of, you know, these kind of feelings between the patients and the providers. We have counseling interventions, which is a support for life stresses and mental health challenges, and mostly, to be honest with you, for stresses that somebody faces in life. Psychological testing, like standardized testing for cognitive, personality, and functional assessment, and that's how they diagnose the issues. If you should, like, you know, have certain tests to assess the cognitive and, you know, the comprehension of the patient, the personality, and especially we are talking about the comprehensive cognitive of the patients. We have also substance use disorder treatment. This is like a specialized care addiction, you know, often integrated with mental health treatment. You know, people who has like, you know, like addictions to certain substances. This is very important group too. And also we have something called evidence-based services. This is like aimed to improve the psychological well-being and functional outcomes. In other words, it's a mental health treatment and programs that are based on scientific research and proven effectiveness. And these are designed to help people feel psychologically better and function more effectively in daily life. So mostly it's a research study, and that's called evidence-based services. Um, Now, we have some data. I want to share with you some data. According to the CDC, 1 in 4 Americans has a diagnosable mental disorder. So adults received treatment in 2022. And according to SAM, it's called SAMHSA or NIMH. And of course, if you go to the bottom of the slide, it's SAMHSA, it's called Substance Abuse and Mental Health Service Administration. And NIMH is National Institute of Mental Health. So according to these like studies and data in 2022, 50.6% of adults with any mental illness receive treatment. So around 50.6%. And for those with serious mental illness, the rate was indeed higher. It's around like 66.7%, which need more treatment. And the percent for those serious mental illness is higher. Now, children receiving treatment, studies from 2021 to 2022 show that roughly 36% of adolescents with depressive episodes receive treatment. Other 2023 data suggests that among adolescents who need treatment, around 8 to 10, around 80% received it, which indicate that while many who need it get help, and there's a significant gap remains in identifying those needs or assessing care, you know. Suicides rank as a leading cause of death. Suicide is currently the 11th leading cause of death overall in the United States. And daily suicide deaths in 2023, there were over 49,000 deaths by suicide, unfortunately, which averages out of to approximately 135 deaths per day, like one death every 11 minutes. And I put all these resources, by the way, in the resources. You can go to those links and the websites and you can check. So in general, these are some data I try to share with you guys about, regarding mental health issues. Now, the common mental and behavioral health disorders, this is our common. Probably we have more, but let's say that's these kind of scenarios that probably, facing during the interpreters or the session. One of them is trauma and stress-related disorder, and as you know, is PTSD, as you know, post-traumatic stress disorder. Very common and important, and we're facing everywhere, the anxiety disorders, including panic disorder, OCD, which is obsessive compulsive disorder, generalized anxiety disorder, and phobias. Like, for example, a lot of phobias. One of them, claustrophobia, that we are facing when you're an interpreter for a patient, you want to go to the MRI. MRI is a very tight space, and the patient said, I cannot do that. I have I'm a panic, or I'm afraid from those closed spaces. This is called claustrophobias, which is kind of, again, an anxiety disorders. Eating disorders, we have anorexia and bulimia. Anorexia, that you don't have appetite. Bulimia, you eat too much. We have also like a neurodevelopmental disorder. This is usually include ADHD and autism spectrum disorder. So autism spectrum disorder is a condition related to a brain development that affects how people see others and socialize with them. So that's called autism spectrum disorders. Also, we have neurocognitive disorders. This is mostly clinically categorized for Alzheimer's and other forms of dementias. And also, we have mood disorders, which include major depressive disorders and bipolar disorders. Severe mental disorders like schizophrenia and other psychotic disorders, and crisis-related behaviors, suicidal ideation, self-harming, related encounters, or also some thoughts of harming others. All these are fall under the crisis-related behaviors. So now, question 2, like for interpreter going to or went already to a lot of mental health sessions, what are the most common barriers you think you have encountered while interpreting in the mental health sessions? I put some choices. If you go like, is it language mostly, or lack of equivalent of terms? Is it fast pace of speech? Is it emotional? Is it limited understanding of mental health system or diagnosis? or if there is any other things, if you can specify, please. We can take 2 minutes for that. This is very important. Okay, so I see most of the answers going with B and C. There is, of course, A and D. Okay. All right. So honestly, I agree with you. Like most of the issues that, and that's what we're going to negotiate now, because this is very, very important. And please, I want you to focus and pay attention with me, because the challenging in the mental health sessions totally different from other sessions. The most important one is the linguistic issues regarding from pace of speech, regarding of miscommunication during like physical, like, communication of speech, or like thought issues or disorder of speech. And also the emotional things. I agree with you. There's a lot of, struggles and dilemma when you're facing the emotional. All right, let's go. So now we have the challenges for interpreters and mental health counselors. This is very, very important, and please, I want you to pay attention. It's classified, according to the study that we did, it's classified to mostly linguistic challenges. We have contextual and cultural challenges, and we have interpersonal dynamics challenges. What's going on inside of ourselves? So the linguistic challenges, the contextual, and the interpersonal. Let's go. Now, let's talk about the linguistic challenges. And this is the most, like big umbrella that we're going to face a lot of issues under this umbrella. As you know, mental health professionals or providers depends heavily on the language, form, and content for diagnosis of treatment, because how he got your symptoms and signs and symptoms? By explaining, by expressing yourself. The provider can build like, a data or a base that he can go from there to diagnose the issue or the disease. The interpreters must deal with nuances, idioms, culturally bound expressions, and technical psychiatric terms. So we might classify this as linguistic challenges to match the plural nature of the possible issues. So nuances is communication, affective tone, language structure may be significant for diagnosis and treatment of effectiveness. So we can like classify the linguistic challenges to 3 categories. We have a fluency disorder, we have formal thought, we have nonverbal alinguistic. The fluency disorder, like issue with the flow of speech. And this is like, you can see that's a lot with patients, for example, stress, depression. This is known as dysfluency, which includes stuttering, cluttering. We have formal thought language disorder. So these are kind of the meaning of an organization of speech. And like example, we have something called echolalia, clanging, neologism, and incoherence. And we have nonverbal, which is alinguistic means of expression. So let's get started. So now dysfluency. Dysfluency by Y, we have 2 words. If it's by Y and if it's by I. So there's by I and that is by Y. So by I, dysfluency is normal, it's a typical, normal temporary interruptions in speech. Somebody pauses during the speech. It's happening to all speakers. For example, use certain words, blah, 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 or stop, or pause. And that's normal. Happen to people maybe with normal hesitations, repetitions. That's normal, not pathological. But this fluency with Y, this is what we want to talk about it, which is like atypical chronic condition or disruption associated with the fluency disorders. And again, like stuttering and cluttering, which often involve tension and struggle. And again, this is like a disruption in the flow, rhythm, and rate of speech caused by a fluency disorder, which lead to a lack of proficiency in producing the understanding ones. This is the problem, lack of proficiency in producing and understanding one's preferred best language. And that's what the mental health interpreters might face. So this fluency can be gross, extremely or extremely subtle, either very subtle or gross. It can be a result of cognitive, educational, and also psychiatric difficulties. And mostly we have very famous things which is called stuttering, stammering, and cluttering, two different categories. So this fluency, as we said, we have two categories, stuttering and stammering. It's the same words we can use interchangeably. The only difference is stuttering is a common in American English, while stammering is preferred in the British English. So in general, it's a speech disorder which characterized by repetitions, sounds, repetition of sounds, syllables, words, or prolongations of the words, for example, stretching sounds, or blocks, which is pause or inability to produce sound. This is where the person stops using speech and make no sounds for certain syllables, which is one of the typical symptoms of stuttering. And that's the stuttering and stammering. The cluttering is a fluency disorder which is characterized by rapid or irregular speaking, like and use excessive filler words like something like that, and words running together. And in other words, is speaking in disorganized spurts, making it hard for others to understand you. And again, this is, a lot of issues that may face both the mental health providers and mental health interpreters. Now, we are talking about the linguistic, which is disfluency. Now we're going to talk about the formal formal thought and language disorders. And we have like four things. We're going to start by something called echolalia. So echolalia is repetition of the words or phrases that child hears others say, for example, because of this. Echolalia is often described as echoing or parroting speeches, like parroting others, repeating what others said. And this is normal, by the way, in children. But echolalia is normal and important part of it's normal part of of early language development. As many children, use repetition to learn and practice language. The form of echolalia typically decreases as expressive language skills develop, especially if it's happened after 3 years of old. Most children naturally reduce or stop echolalia by approximately 30 months of age. However, children with autism spectrum disorder or certain other developmental or neurological conditions may continue to use echolalia behind this age. So that's why echolalia is considered one of the speaking thought disorder if it's passage or past its age limit. If people or kids after 30 months or after 3 years, it's definitely considered pathological if it's after or beyond the 3 years. In autism, echolalia can be communicative and meaningful, not just repetition. That's the thing. That's in autism. But in general, for kids less than 30 months or 3 years, it's not a pathological. Okay. Now, we have a clanging. So a clanging is mostly like expression by sounds, not by words. That's just a general term. Clanging is like a formal thought disorder where a person's words or mode of speech choice is governed by sounds, such as rhyming, alliteration, or punning, rather than by logical meaning or grammatical structure of words. So rhyming, for example, they may include compulsive rhyming. They use boat, goat, coat, I float. Words are strung together because they sound similar, but no meanings, even if they make no sense in context. It sounds over substance. Use sounds to express more than, like an organized word in speech. Alliteration, which is sound connection, repetition of initial sounds where several nearby words start with the same consonant sound without apparent logical connection between words. For example, Sally sells seashells by the seashore. Peter Piper picked a peck of pickled peppers. If you can put some of these in the chat room, that's kind of like, sound connection by letters. Punning, meaning connection, like, this is exploits the different possible meaning of a word where two different words sounds the same but mean different things. For example, like the wedding was so emotional that even the cake was entire in tears. And tears here, they mean like tears. Or words are spelled the same but with different meanings. For example, I am on a seafood diet. I see food and I eat it. So, like seafood, they playing with the words, like it's playing with the words, that's it looks like the same pronunciation but different meanings. So clang is associated with irregular thinking apparent in psychotic mental illness such as schizophrenia, bipolar disorder, for example, in the mania, or in neurocognitive disorders like in dementia and brain injury. Happens especially with the brain injury. Sometimes when we translate with the people with the brain injury or like with a trauma, they happens and they confuse it. They use these of like, the punning expressions, or I'm sorry, I mean the clanging expressions in general. Now we have neologism. This is like a newly created word whose meaning is unknown to others. And of course, neologism is coming from a Greek new like no, and logos, word. The use of neologism is common in children where they invent words. It's called neology to fill gaps in their vocabulary. So like, they invent certain words and with it's going to be a lot of funny, especially for the kids, because try to, fill the gaps in their vocabularies. But it's considered indicative of a brain damage or a thought disorder like schizophrenia when it's present in adults. So let's say we have a neology or a neologism for kids or like, children. That's normal. They create certain words in their word, to use it. But for adults, it's indicative for like a brain damage, especially thought disorder damages like patients with the schizophrenia. Now, the other or the fourth one is the incoherence. Incoherence. This is sometimes called word salad. Speech that is not related together, though the individual words are real words, but the manner in which they are put together reads meaningless, like incoherent gibberish. For example, the question, why do people comb their hair? For example, if you ask like people who has these issues, they will say, because it makes a total in life. My box is broken, helping me blue elephant. Isn't let us brave. Um, it's signed kind of like, really called word salad. I face honestly these kind of, motive thoughts, disorganized speech disorder when I'm interpreting for elderly people or with people sometimes, have issues of, again, like mental health issues or like a brain damage or injury. They have like used words which is totally irrelevant together, and that's called incoherence. So any question so far regarding the disfluency? So if you have any question regarding what we said, you can just put it in Q&A and hopefully I can get the answer. Now, the other one we have to talk about it's called nonverbal or alinguistic. So alinguistic means that's expression of the, like of your vocals or sign utterance that do not follow a formal language. Like, for example, it's not a very formal language. It's mostly like a screams, grunts, yelps, cries, or even moans, which are classical examples of paralinguistic or non-linguistic vocalization that convey high arousal or pain or fear, that rather than the complex ideas. It's more like, to express their pain, their fear, like in the way that you use screams, grunts, yelps, cries. I faced one of these patients when I was working in Brigham and Women Hospital in Boston. The patient is just was so silent, and suddenly, I swear, suddenly screamed suddenly in a very loud voice. Maybe he want to express something, but he cannot express himself in a very formal, organized language. So he express himself with screams, with grunts. So linguistic communication may be observed also in individuals with a severe psychiatric condition such as acute psychosis, catatonia, or profound emotional distress. So catatonia is disorder that disrupts a person's awareness of the world around them. Sometimes react very little or not at all to their surroundings, or might behave in a way that are unusual or unexpected or unsafe to themselves or others. That's called catatonia. It also can appear in people with a neurological disorder affecting language, such as severe aphasia or a nonverbal developmental disorder. So this is like a physical cause. There is severe aphasia. In the aphasia is like aphasia. There's in the brain. There is a center called aphasia, which is responsible for the language. So probably if you have an issue there, so that's like a physical in the brain. We have this thing. So it leads to these kind of nonverbal or linguistic, and also happen in again in developmental disorder, a part probably which is happen also during development. So the interpreters and clinicians should recognize that these expressions convey emotional states or needs, even though they lack like conventional linguistic structure. They wanna express themselves, but they can't. That's why they're using So they mostly the interpreters should know, and also clinicians. This is very important. This is this kind of emotional states that they want to express about it. No questions so far? Yes, I agree. Broca and Wernicke's areas in the brain by this is John Angel. They put that in the yeah, that's true.
And Dr. Zeyad, we have several questions, but we'll get to them at the Q&A here in about 5 to 10 minutes.
Sure. Okay. Now we're going to go to the second category of the linguistic challenges. We are talking about the first one, which is disfluency and blah, blah, blah. And now we have the contextual and cultural challenges. So mental health encounters, it depends on understanding the patient's cultural, social, and situational context, which affects communication. So some contextual and cultural challenges that we might face during the interpreter, and this is also depends on the cultures that's happened most, for example, from like, let's say Middle Eastern people, Asian, somewhere else, African, blah, blah, blah. It depends on cultures too. We have, for example, something's called severity of topics. Now, discussion regarding trauma, abuse, sexual issues, or self-harm are difficult and often hindered by shame or fear of breaking confidentiality, especially when using family members who may be uncomfortable or biased. So this is very important. That we're facing a lot. And again, it depends on the culture. I'm pretty sure we are facing a lot of cultures that they have issues, to talk about the sexual issues, about abuse, and it's considered like shame to share this kind of information and break-ins, breaking with others. We have something called role of confusion. Now, where the family members like often blur the line between interpreters and advocate, resulting in a significant errors, including omission, addition, and substitutions due to lack of professional neutrality in the whole process. And that's why they said it's very important for a qualified interpreter to take role instead of the family members, because again, family members may be omission, addition, and you guys all interpreters, and that's happened a lot when the family members jump in and try to interpret for patients or relative. Now we have linguistic complexity. Now, as you know, guys, mental health requires high level proficiency to capture the subtle nonverbal cues and nuances in the psychological patients and states. Now, untrained staff or unprofessional or family may lack the vocabulary or understanding to convey the complex psychological states or accurately, or terms, and that's leading also to clinical errors. This is very important, and it's happened with the people who are not trained, not professional. They don't have the basics of this kind of process of the interpretation. Now, power of racism. Now, power imbalances can be exacerbated by the presence of a third party and can affect the whole process of the patient communications and how their words are interpreted, requiring interpreters, vigilant, and clinicians to discuss these dynamics. If like a third party, maybe a family relative, like again, jumping and using or try to explain or try to negotiate with the provider on a patient's behalf. Especially that's happened mostly for young age group. Let's say 10 years, 11 years, 12 years, blah, blah, blah. Their parents want to be share or be advocate for their kids. So that's happened. We have something also called stigma and shame. Like mental illness is heavily stigmatized in many cultures, leading to underreporting of suicide risk. For instance, in Asian cultures, to the perception of mental illness as personal weakness or family failure, causing under-reporting. They be shamed to report that somebody from their families tried to be suicide, tried to, hurt himself. That's a very shame to share or break with others. Also, we have something called expression of distress, which is somatization. Psychological distress often expressed through somatic symptoms, example, pain, headaches, rather than emotional, which requires specialized cultural interpret and for the interpreter to correct. Family dynamics. Family interpreters may filter information to protect their image or to hide information from a patient. Example, in case of sexual abuse, sacrificing accurate assessment. And that's very, very common in a lot of cultures. Any sexual abuse will definitely not reporting that. Mental health concepts. Many cultures lack direct equivalent terms of the Western psychiatric diagnoses. Example, PTSD, bipolar disorder, and a lot, requiring cultural brokering by the interpreters rather than the literal translation. Now, the interpersonal dynamics and challenges. This is what happened to ourselves when we are interpreting. We have emotional and cultural nuances, and also we have the power. The emotional and cultural nuances, healthcare interpreter now must convey the emotional intensity, the nuances and metaphors, rather than just little words, as you know, especially in these kind of sessions, often acting as a cultural broker to ensure the intent is accurately and understood, not to capture the patient's intent and emotional notes. To capture the patient and intent and emotional intent is very important. Power of dynamics, manage the interpreter's role, which can shift between. This is very important because the interpreter in the mental health session is totally different from other sessions. You have to always, you have to switch between a conduit, neutral party, and an active participant when cultural, or power imbalances between clinician authority versus patient vulnerability. This is very important. Sometimes the interpreter have to switch between the roles. Cognitive load and fatigue, the intense mental effort of simultaneous interpretation is highly demanded in certain scenarios, especially in the mental health scenarios. You have sometimes to switch from consecutive to simultaneous interpretation mode, and this is very common. So, and especially with a complex and rambling patient speech, stream of consciousness can lead to fatigue and errors to the interpreter, by the way. Now, research shows that mental health fatigue occurs after 30 minutes, of like those kind of interpretation, leading to slower reactions and reduced accuracy and errors. Trust and rapport. Now, building trust with both patient and clinician is a three-person dynamic, while maintaining neutrality and is difficult. So especially when the patient may fear judgment, and fear of talk and blah, blah, blah. Role ambiguity, deciding when to intervene, stopping for clarification, advocate, or provide emotional support. Balancing a provider's expectation with professional boundaries and addressing cultural misunderstandings, often requiring active role management. So this is also important. We have vicarious trauma. So interpreters are exposed to highly distressing narratives leading to risk of secondary trauma, particularly in under-supported scenarios. Vicarious transformation. The positive shift in a trauma worker's inner experience, worldview and personal growth resulting from empathic engagement with the patients and with their issues. Like with with client's trauma material, often seen in a beneficial counterpart to vigorous trauma. It involves building resilience, deeper empathy, and increased gratitude and enhance the meaning in work. Clinical cues. Now, clinicians relies again on subtle nonverbal cues like pause, hesitation, word choice. Interpreters are expected to accurately render these nuances states. So this is very important. It's very hard, by the way, for the interpreters, to get these kind of cues for mental health patients. But, that's part of our job. You have to try to get everything. Now, question. Good 2 minutes for this question. Now, which age group, in your opinion, do you find the most challenging interpreter to interpret for? Give you a minute. So I see most of the answers going with A, D, and E. Yes, and that's true. So young children, that's totally right, because they are very difficult and very hard to, get these kind of, nuances and everything. Adults, especially, yeah, I agree with you. Now, this is very important slides. We have, I believe this one is finish everything. It's called strategies and guidelines. So in general, how much time do we have, Mr. John, so far?
Probably about 5 minutes to wrap up the presentation.
That's great. So give me that 5 minutes, we'll finish everything. So now, this is very important. This is like the strategies that, guys, you need to strategy and guidelines for interpreters, what you need to know. Very important things to preparing and training. If you know today, like tomorrow, you have a session in PTSD, you go ahead and check about some concepts of PTSD, like in general. You can also get some information from the institute that you are translating with, or the place that you are providing with information about what's, for example, are you going for depression? Are you going for PTSD? Are you going for anxiety? So preparing and training, specialized training, essential for equipping interpreters. We have the skills, handle the complexity. You can cope with the mental health encounters, issues. So this is very important. Also, including settings and interventions, understanding the goals, intake. Is it intake? Is it therapy? Is it crisis intervention? Is it individual? Is it group treatment? Helps the interpreter also adjust their approach and realizing the therapy goals. Pre-session briefing. So clinicians should all communicate their goals and expectations to the interpreters to align strategies. This is crucial, because if we discussion the potential terminology, that's very important. The patient's known language issues, the psychosis, is it depression, is it schizophrenia? Maybe there are some, terms that you need to know about it. And familiarize yourself with psychopharmacology. given importance of medication in psychiatric treatment is very important. You should know, for example, about, let's say, tranquilizers, diazepams, trazodone, for example, something like that, some kind of general information about some meds in mental health sessions. Commonly used medications is very important. Also, we have a professional conduct and safety. Remain calm, professional, stay attentive to surroundings around you, and maintain the normal, regular tone. Um, Personal safety, always assess environmental risks and act accordingly. Boundaries, the conduit role is default, but mental health settings sometimes require a cultural broker. That has happened a lot. Like role to be used carefully with the offering counseling. Interpretation techniques, adapt interpretation. This is very important. Sometimes you have to adapt certain kinds of modes. Either maybe you can be prepared to switch between consecutive and simultaneous, cultural broker. Use note taking for rapid, lengthy patient speech. Use first person, very important. Encourage providers to speak directly to the patient using I and you rather than addressing the patient. Now, also, there is something very important by organization and system level support. Organizational support, healthcare system should provide adequate support, training, recognition of healthcare interpreters to ensure quality and sustainability of the services in the mental health sessions. Patient support by providing the same interpreter for a patient throughout their treatment, the continuity of the care. This is very important for the patients and build the trust and help others. Now, I want you guys to do this homework. I'm going to put that in the chat. This is like if you can do that in your own language, that's like as a homework, guys, for you. So, yeah, we have echolalia, cleansing, all these kind of things. Finally, I'm going to share with you also these links. Let me just do like that. These are some general information, links and information that you can find, and you can get just the last one. If you are interested to get more information. And thank you so much for having
Thank
me. I
you.
appreciate that. And I'm hopeful.
No, thank you, thank you, thank you, thank you very much, Dr. Zeyad. It's um, profoundly informative. It's really, really comprehensive. There's so much to mental health interpreting,
That's
um,
yes,
and it's difficult to find a lot of good resources. So it's great to speak to a physician who is familiar with obviously the terrain and familiar
yeah,
with the role of an interpreter. I feel like a lot of times, sort of the interpreters sort of challenges, standard challenges, right, about role boundaries and just accuracy as a conduit are kind of magnified within a
right.
mental health setting because it's a lot of ambiguity. It's a lot of different things, right? You don't know when maybe the evaluator is trying to trigger
Totally agree with
the
you.
the the, the patient.
That's the issue because you need almost always, to update yourself with everything, to be honest with you. So that's why it's
Absolutely.
important. If you can get information before the session,
If you
that
could
would
have
be
a pre-session just to have
exactly,
some idea. And
exactly.
then obviously just to make sure they're aware, hey, this is my role. Um, so that they don't, yeah, so that they can think of our role appropriately. If you want to stop sharing, that would be great. If just to if you could see the button at the top, I'm not sure about stop share. If you
Um,
could find it.
let me just figure out what to
Let me
oh,
see
stop
as
share. Okay.
well.
Me in the
There
bottom.
we go. Perfect. 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 Excellent. So we do have a few questions. I don't know if we're going to get to all of them. We actually have a ton of questions. So we'll just start and and just see where we land. So we have one question from Cecile. This was pediatrics. So how do you work with patients that are present, obviously during the encounter, and are trying to control their children's answers? I am talking mostly about pediatric visits and screening. I've had parents asking children, in parentheses, teens, to change their answers when they said they were feeling sad or hopeless, for example.
Well, honestly, it's very important that you inform the parents. It's very important that the kids let the kids express themselves because this is maybe a very important part of the treatment process. If you are gonna like silent your kids, they cannot express themselves. You won't be able 100% to get the whole story to build the treatment plan. If you encourage patients and explain to them, I'm sorry, the parents, that's very important to let them know, and they will hopefully they will respond or apply to that or comply to that.
So you're in the encounter, it's happening. Uh, do you do it? Let's say you didn't have a chance for a debrief. Ideally, you're able to debrief and kind of brief the parents on the role of the interpreter through your professional introduction. Let's say they continue to try to change the answers. Do you do that, or maybe do you point it out so that the clinician, the evaluator,
Honestly, Mr. John, the clinician should do that. But in case when you are using the interpreting and you are noticed that the parents are keep like as the question said, keep silencing their kids and they try to express on their behalf.
yep,
So here you ask permission
yep,
from the provider that, sir, I see there's some culturally things there. I wanted to clarify for you. I want to let the parents let their kids to express themselves. You cannot jump, of course, and and do
and assume that
the
that's
role
what's
of
going.
clinicians. To be honest, but honestly, Mr. John, I didn't see clinicians do that. It's very rare. You know,
Really?
it's very rare. Especially yes, especially that's happened. Like for the young kids, like let's say 5 years, 6 years, because they cannot express like elderly, like let's say 12 years, no, that's happened. Let them talk and blah, blah, blah. But for young kids, like again, 5, 6 years, you should do that if, ask the permission from a provider to do that.
Okay. Okay. No, excellent. Excellent. Um, okay. One question from Deborah. In the rhyming context, towards the beginning of your presentation,
Yes.
if you translate the word, it won't rhyme in the other language. It's trying to interpret a joke. Recognize it and say a series of rhyming words in English to the provider, or translate the words and make interpreter note regarding apparent rhyming. Yeah, how would you handle that?
So it's very, very simple answer. You get the rhyming in their own languages, not the translation language.
Yep,
I'm translating from Arabic to English, for example. I'm not say to the guy or to the provider that this is rhyming in the English. No, I am translating from Arabic. If I hear the Arabic patients rhyming things, I will let the provider that they are rhyming.
they're rhyming.
Because that's in their own language, technically, as you know, because we cannot like judge on the
Yep.
translation. We are depends and we build our story on the primary language.
Okay. No. Yeah, very true. It's so important with this example. Um, even though it'd be tough to see this example coming, and also the prior example, to try and have scripts ready, just scripts that help you point the issue out. Um,
So, for example, in Spanish language, and because the Spanish are more popular in the United States, the Spanish interpreter, he will tell the provider that they are rhyming when they hear it in the Spanish language, of course, in Spanish dialects and blah, blah, blah. They did that. They will let the provider that they are rhyming because it's maybe a part of the pathological issues, patch of the
yep,
mental issues. Yeah.
very cool. Very good, 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 good. Fascinating. Just a quick housekeeping item for everyone that joined us. Just know we're at the hour mark. We're going to address, Dr. Zayed is generous enough to hang out with us for a few minutes so we can go through some of the questions that were put into the Q&A. But you are free to go. You will, as long as you stayed for an hour, you will get the CEs. Um, okay, so next question from Sandra. Um, yeah, so it's kind of a follow-on. My question is, if interpreters should make the provider aware, and how should they make them aware if there are difficulties interpreting because of these speech patterns?
So the most important thing, any question you have for the provider, you have to write it down in your notebook, for example, because this is very important.
Yep.
And if it is something very urgent and important, for example,
Yep.
there's kind of information that you get from the patient that he's going to do a suicide effects or
Yeah.
suicide. Very important to let the provider know, even by intervention, doing this, Mark, please, can you give me one
Raising
more?
your hand.
Can I
Yep.
explain to you, please? I hear the patient, he has some suicidal thoughts. So very important to stop the provider because, again, this is maybe probably two things. Either it's going to be a crisis, you have to stop it, or either this would be like a part of the treatment plan. When the provider, the interpreters are the provider's eyes and brain. If he missed something, unfortunately, you missed it or not tell them, they might probably like doing a wrong treatment plan. And this is very, very important.
Okay.
For
Okay.
example, like rudeness. Some interpreters try to be hesitate. One of my
Yeah.
colleagues tell me, Ziyad, do I have an interpreter like the rudeness? I said, it's very important because it's a part of the pathological process of the patient. So very important. He might be, like be profanity terms to the
Yep.
doctor. You should
Yep.
tell. Again, we are a conduit, but again, certain, and doctor knows he's a mental health patient. He
Yep.
probably gets a rudeness, something. You are the brain and eyes and ears of the doctors that he think, and that to translate everything and let him know, especially about the cultural nuances and all that kind of some things.
Very true. Very true. So important. So important. From Gloria, where does Tourette's fit into the speech disorder kind of challenges?
What is the question again? I'm sorry.
Where does Tourette's, the speech
What is
disorder of
correct?
Tourette's, fit into the speech disorder challenges?
I didn't get the question. I'm sorry, Mr. John.
No,
Sorry.
we can. So it's actually where does Tourette's fit into the speech disorder? That's all we have, speech disorder. Hmm. So I may have, yeah,
So the question talking about the speech disorder.
yeah, of Tourette's.
Oh, after repetitions.
Tourette's. We can, yeah, I didn't capture the full question here, so we could
Yeah,
actually,
okay,
let's skip
I
this
didn't
up.
get the
We could
question.
probably come back to that. Um, okay, this is a really good one from Anna. I'm wondering how much of the language disorders fluency can cross the line into pathologizing cultural expression, idiosyncrasies, and creativity. Even if there is neurodivergence present, how, as interpreters, can we be mindful of this?
Uh, what the question briefly one more time, if you don't mind, Mr. John, please.
Yeah. How much of the language disorders,
Disorder or disfluency?
disfluency, yes, disfluency disorders can cross the line into pathologizing cultural expression,
So
idiosyncrasies, and creativity?
yeah, so
It's a bit of a theoretical question.
most important thing that um, uh, we are not like judging if
Yep,
this is like a pathological, this is
yep,
normal, it's part of the process. We are not a mental health specialist.
yep,
Our role is to get all the information and nuances and issues and disfluency as we can from the patients and translate it to the target language to the provider.
yep,
So, but definitely the disfluency, regardless if it has is if it's a pathological process, if it's a mental thought disorder, affects a lot the outcome for the treatment plan. First, affect a lot the interpreters because it's very hard to get it. To be honest with you, it's very hard. If the patients, like for example, use like say clanging, use the sounds, use those kind of or like putting certain new words or something's called the word salad, which is the incoherence.
yep,
So
yep,
it's very hard for you. The only things to do is just to translate it to the provider. This webinar explaining what these symptoms and signs means, but does that not mean that we are judging? Because probably they will
Mm.
like that what they are studying. They
Yeah,
will know exactly what is the pathological process behind these disfluency or the issues in the language or linguistic things.
absolutely. Absolutely.
Yeah.
Oh, excellent. Um, can you, this is from Alma, can you please provide an example of how an interpreter manages the power dynamic in mental health interpreting? Do you have any suggestions of how we as interpreters could practice or improve matching the tone and the nonverbal communication, like pauses?
Do you mean how to manage the nonverbal patients? How to manage that?
Yeah, I think it's and this is I just asked the question the way it was posed. Any example about how to manage the power dynamic, uh, let's say probably between, a clinician, a provider,
Yeah, yeah, yeah.
and then someone that is a patient that just finds themselves in a very vulnerable situation. And they may feel shame or they may feel just a lot of angst in the moment. Um, and because of that, maybe they're providing some sort of a shell, some sort of a
So yeah. So again, because I'm not a mental health specialist, but I'm gonna answer you regarding for as an interpreter. If we get in this scenario, if there is a
our job, what we
our
do
job,
within our
yeah,
scope of practice.
yeah, exactly. If we are an interpreters and there is a non-verbal communication, what we shall do, for example, there's some we have like some powerful, like some power dynamics to non-verbal communication. For example, the interpreter is standing up while others are seated to command attention. Now, using a firm handshake to establish authority, for example, placing themselves like strategically in a room to
Mhm.
facilitate the equal access. So these actions, like balanced communication, allowing interpreters to act like, as, like, let's say liaison, they will pay attention to them. So, in the medical setting, you might choose to stand to ensure all parties have equal access, for example, to visual and spoken information.
Okay.
Um, yeah, and also, I try to think what else. Um, yeah, I mean, very important also like turn taking like turn taking, managing the
Yep.
turn taking for non-verbally.
Yep.
Yeah, like, use hand signals, very important, like, they hold up, time out, blah, 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 something kind of these.
Pauses, the gestures to sort of manage the flow, because
That's
that's the
true.
most difficult part. That's the
It
parts where
is.
you
It is.
really, there's a dynamic and you're trying to
It
get
is.
them to communicate and they're having to communicate through you. So how do you sort of just get the message and get them to implement a pause, which is really difficult with a patient, a mental health patient, because they're not picking up those cues. The provider is.
I swear to God, yesterday at night, when during my shift, I faced an issue like this. There is an elderly lady
Mhm.
that was translating for the provider. It was a nurse. So the nurse asked her, and I said hello in Arabic, blah, blah. She just answered. Then after that, any question, she's not communicating. She's not
Yeah.
just gazing.
Mm.
And when the provider asked her in English, she said certain words, but not like, very cool. I don't know why she's not responding. And this is weird. It's happened to a very elderly lady. It's happened, and this is weird. Again, this is like indicated there is something wrong, either pathologically
Yep.
or in a mood, or some people they're in a mood.
Yep.
I was communicating also, translating for a patient, and the patient said he wasn't answering me. I swear. And I asked the provider, "Can she speak?" She said, like 10 minutes ago, she was communicating with her son. Sometimes even for like stranger people, sometimes some patients, especially the mental health, considers the interpreter like, a stranger, like, foreigners. They won't, get so
Mm.
much to use to talk to them.
Yeah. Very good points. Very good points. And just a quick reminder, we're going to take two more questions, uh, but you are free to go. If you'd like to listen to continue to listen to the conversation with Dr. Sayed, please hang out. but we're going to take two more questions. CEs will be available. You'll receive an email in about 24 to 48 hours. From Virginia, do you keep the same interpreter throughout the 8 hour mental health session, or do you
I'm sorry,
rotate
I couldn't hear you,
interpreter?
please, Mr. John. I
Sorry,
apologize.
can you hear me? Can you hear me okay now?
Yes, yes.
Okay, sorry about that, the
Yeah,
mic.
you're good.
Do you keep the same interpreter throughout the 8 hour mental health session, or do you rotate interpreters
No, of course
after?
not. By the way, it's very important to keep it, but no, you're going to be exhausted. The aim of the interpreter to get a very accurate translation interpretation.
Yep.
Any interpreters for 8 hours in a mental health session, like continuously, I believe this is does the question means for like many patients or like certain case? I
No,
want
I
to.
think the specifics of this question is, as a mental health interpreter, how long of a session can you do just by yourself of continuous mental health interpreting? And there's no reason it should be any different from simultaneous. Well, it is consecutive, but I would think you should be advocating for yourself. Obviously, simultaneous will be about anything beyond 30 minutes. You need a partner. If you're doing simultaneous in mental health interpreting, it's the same thing. You need a partner. You need to advocate for yourself. Um, but if it's consecutive in mental health interpreting, um, I don't know
Probably it
that there
depends
is
on
a
the interpreter
established
themselves, to be honest with you.
guidelines, but I would say probably 2 hours.
Probably,
And
I
that's
believe
about the extent of an
I
intake.
totally agree with you, Mr. John. So 2 hours is the minimum. And
Yeah.
also, to be honest with you, it depends on the interpreter themselves. If the interpreter has like a long, spirit, and he can tolerate, he's good, he's professional, he has good back knowledge.
Yeah.
Probably he can tolerate more, especially if it's like, like let's say you are like working in a mental health session in a hospital
Yep.
and you are like hired there as an interpreter. So you can, for example, do
Mm.
this session, let's say 45 minutes, an hour with the patient. You have like a break for 15 minutes. You can go. It's like a normal, regular employee. But again, it depends on the kind of the sessions, the mode of interpretation, as you said, Mr. John, simultaneous. It's a crazy mode of interpretation for the mental health sessions and interpreters. It's
Yep.
very hard. So because you try not to miss anything, this is very important, and it's very hard to cope everything with that. But if it is like consecutive, then it's okay. I believe it depends again on the interpreter and who he can cope and using his own strategy. Yeah,
But the rule of thumb is really 2 hours.
I
It's
agree with you. Totally agree. Yes. Yeah.
okay. Wonderful, wonderful. So last question. In your experience, Dr. Zayed, what is something interpreters often miss in mental health sessions that is not about language?
Well, language is very important. That's number one. And the other things is the cultural things is very important. So, for example, let me give you an example. I am from, uh, let's say, for example, you, Mr. John, let's say you are from Mexico.
Mhm.
You have a patient who is talking Spanish, but he's from Ecuador, for example. So you are guys talking both languages, but there is the cultural things that you might probably missed when you try to explain or like translate to this patient. So cultural things are very important. The backgrounds of the patient is very important. If you know that you are translating for certain things in the culture. For example, I am from Middle East. If I am translating to a patient from Africa, so if I don't know that this kind of culture, there's very shame talking about the like kind of like let's say sexual abuse
Yep.
or let's say addiction or suicidal thoughts. So if I don't know the culture in the Western world, this is normal. You can express, you can talk about these kind of things to solve the
Mhm.
issues. But in other cultures, if you don't that, you will miss a lot, honestly, from the cultural things. But again, the language is very important. That's number one, because again, mental health sessions need special attention. But again, the cultural things, in my opinion, is very important. Very important.
Absolutely.
And because we are not translating always for one patient from your country. We
Yep.
are dealing with, a lot of people and a lot of different
A
dialect.
lot of differences.
Yeah,
So a lot of
yeah,
different providers, a lot of different patients, a lot of different circumstances. And that's just mental health. Then there's obviously all of healthcare.
I agree.
Yeah,
That's totally true.
absolutely. Well, thank you. Dr. Zeyad. This was a wonderful session. We learned a ton, and we
Thank
know
you
that we just
so much.
scratched the surface.
I was really happy with you, Mr. John, and other team, and then all the you know, the audience. So, and we can keep together. I just want to be sure that you're going to send me my also my certificate through email, correct?
Absolutely. You're going to get your certificate, Dr. Zayed,
Okay.
in about 24 to 48 hours. Thank you again. Thank you so much for generously sharing your expertise. Thank you all for joining us this month. We have another presentation, another webinar here in early June. Please, 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 if you have not, please subscribe to our newsletter. That's where we publish everything. Have a wonderful day, everyone. Thank you so much. Thank you, Doctor.